Welcome back to MedSynapse podcast. Today we will invade new adventure into neonatal. We are so glad to announce about our guest, Dr. Sridhar. He is neonatal consultant. Today we'll discuss a topic very critical. It may affect the whole life of family. So we will discuss antenatal screening overview. Dr. Sridhar, welcome on board.
Thank you, Diana. Thank you so much.
Thank you so much for having you today. And we trust your support to all families and physicians with a lot of interested information and valuable as well. So we will start from the basics, Dr. Sridhar. And what is the antenatal screening and why it's very important?
So one of the reasons I suggested this topic is there's a lot of misinformation in the community. And many parents are exposed to the antenatal screening tools, but without understanding the full implications. So pregnancy, as you know, is a very important stage in any family's life. And there is a lot of uncertainty when pregnancy starts as to how the baby is going to be. We all expect a healthy pregnancy with a good outcome, and that's the hope, and we pray for it. But in some situations, you have problems. And antenatal screening is a method to pick up problems during the pregnancy at different stages. So you might have problems related to growth of the fetus. You might have problem related to the way the genetic makeup of the baby is. We may have trisomy, for example, and we may have problems related to infection. So we have different components of the antenatal screening. So broadly speaking, we have some tests which are done in all pregnancies. We have the screening of the mother for infections like hepatitis B, HIV, group B streptococcal risk, and so on. We have tests done to pick up diabetes in the mother because pregnancy, having diabetes, affects the outcome of the fetus. So we have vaccination, which specifically tries to reduce the risk to the mother and the fetus. Recently, pertussis cases are increasing. So though it's not screening, it's part of the antenatal measures which target the fetal well-being as well. But when we say antenatal screening in general, it mainly focuses on Down syndrome or trisomy screening and the related ultrasound anomaly scan and the multiple tests that are available. And sometimes the screening tests lead on to further testing, which we will discuss today.
Great, and really it's very critical for all mothers to be. So, Dr. Sridhar, what are the standard trisomy screening tests used during pregnancy?
So basically, trisomy screening, it started with looking at risk of Down syndrome, because as you know, Down syndrome is 1 in 800 pregnancies can have Down syndrome, but as the mother's age increases, the risk increases significantly. So this is one of the conditions where the maternal age leads to aging population of the ovum, and that leads to an increased risk. So if a 45-year-old lady gets pregnant, there is a very high chance, less than 1 in 100 chance of getting trisomy, even though in the population, which includes mainly the young people getting pregnant, the risk is put as 1 in 800. We have the other trisomies, the trisomy 13 and the trisomy 18, which are not as common as Down syndrome, but still they occur reasonably commonly, 1 in 4,000 pregnancies or so. And we have the sex chromosome disorders, the Turner syndrome, which is the most important. And of course, the pregnancy screening for trisomy starts right from 10 weeks onwards. And we have different tests. So one of the key points that the parent should be informed is what exactly they're looking for. Trisomy, they need to know, because a lay parent may not know Down syndrome, even though most of us have seen children with Down syndrome either in the family setup or in the neighborhood, or you may be going to supermarkets nowadays and see children or young adults with Down syndrome working. You might have Down syndrome children in your child's school and so on. Though we are exposed, most parents do not know exactly what Down syndrome is, what the implications are. Because when you agree to do a screening, you also need to have a clear idea of what you will do next if in case the screening comes abnormal. So we have screening as a first step. I'll tell you the stages for it. Then comes the diagnostic test. If the screening comes as high risk, either because of the tests or the test with age together or the test with age plus scan results together, then we need to decide what the parent would do. If they face a pregnancy with trisomy 18 or 13, most parents would agree to terminate. But trisomy 21 is a condition where we see children living up to 40, 45 years when they grow up and they function reasonably normally, though they're not exactly normal. They have a lower IQ. They may need support through life to perform their routine, but they do give joy to their family members. They are individuals with their own bubbly personality. So the parent should be clear, and you may have a religious reason, you may have like Catholic groups or Islamic groups may not have abortion as an option. So in that case, diagnosing it in the pregnancy helps you mentally prepare, but it doesn't change the outcome of the pregnancy. You will still deliver the baby, you will still manage. So screening can be done for everyone just to act as a warning, but then when you come to the diagnostic test, which we will discuss next, it's about more invasive tests. So if you are not going to act definitively, it's as well to monitor the scans in non-invasively and not act. So the first step is to understand the condition. The second step is to decide what your approach would be, so that if you do come across an abnormal result, you're mentally prepared, or as a family, you discuss and decide. And of course, that's the reason the parent should ideally go through a consenting process when we ask for screening. So according to the stage of the pregnancy, the screening can be different stages. So the stage one is when you pick it up at 10 to 14 weeks. If the mother presents at 10 weeks, you offer them the first trimester screening. The first trimester screening is very sensitive, and there is more than 80-85% chance of picking up Down syndrome as a risk. And here we are doing nuchal translucency, which is one of the findings on the ultrasound. And we also do two markers on the blood, which is beta unit of HCG and the PAP-A, the pregnancy associated plasma protein A, the mother's serum. So if there are other soft markers, even on the first trimester scan, like a flat nasal bridge, that can be incorporated, and the mother's age is always counted in. So as I mentioned, the mother's age itself brings up the risk of trisomy, and if the mother is old, there will be an age-dependent revision of the risk. So according to the mother's age plus this findings, you give overall risk. And the risk that you accept, some units use 1 in 250, some units take 1 in 150. The UK screening, for example, takes 1 in 150. So the range that you select will also say how many mothers are going to be included in this risk. If you take 1 in 250, that's wider. So more mothers will be coming up as high risk. If you take 1 in 150, you're filtering out those between 150 and 250 risk. So obviously you have to choose the cutoff that you're using in your area, and then the parent should be aware of this as well, that the risk profiling brings up the risk as high, but it doesn't rule out. Even if you come as low risk, it doesn't rule out the problem. You still continue to monitor the scans as the pregnancy progresses. There are some mothers who don't agree for the first trimester screening, or they don't get in time to the obstetrician to do this. If they come beyond 14 weeks, then we have something called second trimester quadruple testing. So the reasons quadruple testing is less preferable to first trimester screening is because the sensitivity is lower. It's around 70%. And it also doesn't usually pick up the other trisomies like 13 and 18. It's more for trisomy 21. So here there are 4 tests that are included. We have the beta HCG again. We have the estriol. We have the alpha fetoprotein as well. And obviously we have 4 tests included in this plus the scans. And when the conditions are picked up on this testing as high risk, again, the maternal age-related risk is considered as well. So we have to look at that and adjust the risk as low risk or high risk. And then we come to the point of high risk as to what you would do. So we will discuss that next.
Great. So, Dr. Sridhar, by focusing on some techniques and some testing, so what is NIPT or non-invasive prenatal testing, and how does it compare to other testing methods?
Yes, this is a very important question because we discussed the screening tools, and actually in the last 10 years or so, we have an advanced screening tool. This is called non-invasive prenatal testing, or in more specific terms, cell-free DNA from the fetus in the mother's sample. So it's called cell-free DNA testing because the placenta has a fetal portion of it, and the cells are constantly shed when they die. It's called apoptosis. And this component actually enters into the mother's blood. And when this DNA from the fetus enters the mother's blood, by sampling from the mother, we can actually pick up the fetal chromosomal typing. So we have different tests that can be done on this. I said it's a screening test, but for the trisomies, it has a very high sensitivity and specificity, almost 98-99%. So it can be as reliable as a diagnostic test for the trisomies. But for the non-trisomies, the sex chromosome disorders, because there is a higher chance of mosaicism, which means there are 2 different cell populations and there may be confusion. So it's about 90-95% reliable. But when you go to specific wider range of NIPT testing, we start testing for genetic problems, we start testing for deletions and so on, then the sensitivity drops. And when the population incidence of a particular condition is low, you may get more false positives for it. So you end up doing an invasive test after the NIPT for something you may not have done otherwise. So if you are restricting the use of cell-free DNA to trisomies, it works very well because you can actually rule out the risk of trisomy without doing the invasive testing. In majority of the cases, if you corroborate and it reassures the parents without having to risk losing the pregnancy, we'll be discussing the diagnostic test next as well. But in terms of approach to the high risk screening test before, nowadays our approach is changing. If you have the first trimester screening abnormal, you can offer NIPT to the parent. If you didn't get the first trimester screening, but you go for a quadruple testing, you can get the NIPT if it comes high risk. There is no use of doing the quadruple test after a high risk first trimester screening because this is actually an inferior test. The only reason you do the quadruple test is if you can't do the first trimester screening. I see many parents reporting to me that the obstetrician has requested a quadruple test because the high risk on the first trimester. So this is wrong. Please don't do that. You just need to go for the NIPT test in these cases. The only problem with NIPT is that it is expensive. But as more and more tests are, more and more companies are coming out with efficient tests, the cost is dropping. Actually, in US, they are offering the NIPT to any pregnant woman because it's a sensitive screening test. And if you look only for trisomies, you're not going to confuse the family. But if you use a wide range NIPT, you have to pick the choice. I mean, you can either choose to do just the trisomies and you can do the wider testing. If you do the wider testing, it may come out with some results which may confuse you and may make the decision making more difficult. Of course, you can also do gender determination on the NIPT for any reason you want to. You are looking at a X condition where the X chromosome brings a disorder. The male will be more severely affected. So if you want to identify the gender of the fetus, you can do that. If you know already a particular genetic condition in the family, you can go for specific gene testing on the NIPT as well. So according to the nature of the test, you can either get the result by 24 to 48 hours, or it may take a week to 10 days to get the NIPT result. So this is a real blessing available, and more parents should be familiar with that. And the doctors who are looking at the result of the screening test should be looking at that as well, because they should be clear when to do the NIPT. If the NIPT comes abnormal, you don't terminate a pregnancy based on that result, even if it is abnormal. You would still want a diagnostic test because, as I said, this is shed from the placenta. There is a small chance that it may not be from the fetus directly. The cells might have changed in the fetus. So if the NIPT comes abnormal, you still do a diagnostic test before definitive action. But if the NIPT comes normal, it's very reassuring and you don't necessarily need to do the invasive test. I hope this point is clear.
Yes, yes, it was great. So, Dr. Sridhar, what are some examples of soft markers in antenatal scans and why are they important for risk assessment?
This is one of the biggest problems we have, soft markers, because they are soft markers, they don't give definitive information, but it is going to report abnormalities in the brain, the kidney, the heart, and so on. So the parents are not understanding this concept that what we are looking for is just an additional marker which indicates that the baby could be at risk. It's not that the baby has the condition, but could be at risk of certain problems like trisomy. So soft markers are basically ultrasound findings which have been noted over the last few years, like 20, 30 years, that there is an association of some of these soft markers. The reason it's an association is because it doesn't happen in all the pregnancies with this soft marker. Majority are still normal, but compared to the general population who don't have this soft marker, the pregnancy with the soft marker has a higher chance. So which particular pregnancy has a higher chance is what we need to look at. So soft markers, I'll just explain a little bit about each soft marker, and hopefully we'll have some images added as well. So we have single umbilical artery, which is the most commonly discussed. Single umbilical artery means we have the umbilical cord with 3 vessels in it normally. So one of the veins disappears. That's why we have only one vein left and we have 2 arteries. In some pregnancies, there is only 1 artery left. That's a variation. And there may be some impact on the fetus in terms of higher resistance to the blood coming back from the fetus. Growth restriction may be more But apart from that, there is an observation that there is this single umbilical artery is more common in trisomies, but very rare that the trisomies would have just this single umbilical artery as a finding. You would have either the screening tests abnormal, or you'd have other abnormalities on the scan, like heart defect is picked up, or there is a facial abnormality picked up on the scan. So you might have corroborating findings in the scan which point to the trisomy. So if it's an isolated single umbilical artery with a normal pregnancy screening test, either the first trimester or the second trimester, you either can continue the pregnancy as it is and monitor the fetal growth, or you can opt for an NIPT if you want to be reassured. But in majority of the situations, NIPT will come back normal. So if cost is a significant concern, you can stick with that decision. So don't be alarmed about it. The other soft marker that's commonly discussed is something called the choroid plexus cyst. So this becomes a scary situation for parents because it's something that's reported as in the fetal brain. We have a fluid filled space in the brain called the ventricles, and the ventricles produce a fluid called CSF at their base. The part which produces the CSF is called the choroid plexus. So cerebrospinal fluid is a fluid that circulates in that chamber as well as in the spinal canal. So this fluid producing part is called the choroid plexus. It's more vascular, more blood vessels in it. But in real terms, we have the choroid plexus breaking down in some areas, and this is called a choroid plexus cyst. It may be on both sides, or it may be on one side. It may be small, it may be large. In general terms, a choroid plexus doesn't have function. It's in the brain, but it's not part of the brain. It's only a vessel, blood vessel part, which has a role in secreting fluid. If there is some defects in it, it doesn't affect its function. The fluid is still produced normally, and it has nothing to do with brain function. So if the overall imaging of the baby is normal, the presence of the choroid plexus cyst should be a marker that there may be a higher risk of trisomies like Edwards syndrome or trisomy 18. But again, it's a marker. Majority of the babies with choroid plexus cyst are still normal. If it's a very large cyst, you may consider doing an NIPT again to rule out Edwards. And you do have the first trimester screening report to support you. If it's normal and the other scans are normal, you can choose if you want to be sure to do the NIPT. But after the baby is born, these cysts usually disappear by themselves. There is no need to repeat the scan after birth, and the baby develops normally. So this doesn't impact the development. Another soft marker associated to the brain is the ventriculomegaly, where the same fluid-filled space I described becomes a little bigger. There are ranges according to the maturity of the gestation. Again, it's a soft marker. There may also be a risk of hydrocephalus if the head size is bigger or this fluid-filled chamber grows with time. So you have to decide what to do at that stage and continue to monitor the scans. Very rare to terminate pregnancies based on this alone because you'd have the ability to treat the babies with a shunt. So picking up antenatally helps you to treat them. But again, if it is just ventriculomegaly without enlargement of the head and the size doesn't progress, if the rest of the screening is normal, you don't need to worry about it. With any soft marker, you can be offered NIPT to be reassuring. Then we have the echogenic intracardiac focus, hyperechogenic focus in the heart. This appears as a bright area when you do the fetal scan for the heart. And this bright scan is nothing but a hyperechoic part of the fetal developing heart muscle, papillary muscle to be specific. And in many pregnancies, this doesn't progress to any heart condition. So if you see that a hyperechogenic focus, it's better to do a fetal echo to make sure the heart looks normal because there may be other problems which mimic the bright echo. So if it is ruling out heart problems, the rest of the screening was normal. Again, you don't need to worry. And once you have done the fetal echo, there is no need to do an echo for the baby after the baby is born. You can just monitor the baby. So hyperechogenic bowel is the other condition where the gut, the GI tract looks bright. So the brightness is depending on how much gain settings you keep on the machine. So the sonographer should be experienced enough to adjust the gain so it's not reported false as a brightness when it's actually due to your settings. The hyperechogenic brightness in the bowel is usually due to swallowed fetal blood. During the early pregnancy, there may be some blood spotting into the yolk sac and the baby can swallow it. And this appears as bright specks because blood is bright. But of course, you may have associated conditions like cystic fibrosis, intrauterine infections, IUGR growth restriction by itself can cause the stool to be impacted and causes a bright speck. In these cases, the approach is the same. You do the first trimester screening, you do the anomaly scans. If the rest of it is normal, you can consider NIPT. If there are specific signs that point to growth restriction, you can look for intrauterine infections. But if the baby is growing well, you continue to monitor the scan. If there is a gut obstruction, the bowel will start dilating. Here also, you don't need to terminate the pregnancy because even if there is a bowel obstruction, most of these are amenable to surgical treatment. So only thing you should refer to a center which has the ability to do neonatal surgery. If the scan shows widening of the gut becomes big, the echogenicity suggests. So this is a small percentage of the fetuses. Most of the fetuses with echogenic bowel will be normal. Now, the short femur is a growth concern. Often it's looked at as a soft marker as well. Same with the renal pelviectasis. So we have the kidney pelvis, the renal pelvis. It may appear enlarged in some pregnancies. There is something called hydronephrosis, fetal hydronephrosis, where in addition to the pelvis becoming big, there is also evidence of increased pressure in the system. The smaller parts called calyces also become dilated. The ureter, the tube may be dilated as well, and this can reflect some form of obstruction to the urinary flow. But just the pelvis becoming dilated can be considered as a soft marker. And again, the approach depends on the size. You may choose to just monitor this if the rest of the screening is normal, or you may do an NIPT as well. So we have these major things that we discussed. So hyperechogenic bowel, pelviectasis, ventriculomegaly, choroid plexuses, single umbilical artery. These are all soft markers, and often we get many messages from parents that mention that the doctor has advised to terminate a pregnancy based on this. That's absolutely wrong. And you don't need to do invasive testing directly. Now we have the NIPT. If a soft marker is there, if the rest is normal, but you're still worried, go ahead with an NIPT, which is a non-invasive test on the mother's sample. Though there is a cost involved, it will at least reassure you. And once you make a decision on what to do, don't keep thinking about it. Very unlikely that this soft marker will affect your baby's progress. So just be reassured and monitor and enjoy the pregnancy, because the maternal health status will be important for the baby's health as well. If your mother is anxious, there is a higher chance of preterm delivery, and many times we don't need to do anything more.
Yes, definitely. So, Dr. Sridhar, it's time to move forward diagnosis. So, what are the diagnostic tests and how they differ from initial screening tests?
So we discussed already about the NIPT being a fairly good screening test because it's almost diagnostic. It doesn't categorize as diagnostic because you would not take an action based on that. So you would not intervene with the pregnancy outcome. You would continue the pregnancy if it's normal, but if it is abnormal, you would go for a diagnostic test. The diagnostic test is going to give you a clear result in majority of the cases. There are some fallacies even in the diagnostic test, especially if there are two cell types, but that's not common. So we have two main diagnostic tests which are done: chorionic villus sampling and amniocentesis. The chorionic villus sampling can be done as early as 9 to 10 weeks of pregnancy. If you do it between 8 to 9 weeks, there is a higher chance of defects in the baby. You may cause limb reduction defect. You have a higher chance of pregnancy loss as well. So preferably you do it after 10 weeks. It's done ultrasound guided through the mother's vaginal tract in the early stages of pregnancy. If you do a chorionic villus sampling later in pregnancy for any reason, if you can't do amniocentesis, you would do it as ultrasound guided through the abdominal wall. So the chorionic villus is nothing but the edge of the placenta you are catching at the lower end of the mother's introitus, and you're taking a sample from that. Usually it's a placental sample, so there is a small difference between the placental sample and the baby's own sample. So that has to be kept in mind when you analyze. That's why some percentage of chorionic villus sampling have mosaic results, and then you may either need to repeat it or go for amniocentesis if it's later in pregnancy. The pregnancy loss rate with the ultrasound guided chorionic villus sampling with modern techniques is 0.2 to 0.5%. It used to be 1%, but it has dropped significantly. So it's a fairly safe process if it is done in experienced hands. Amniocentesis is where you're tapping the fluid from the sac surrounding the baby. So you're doing ultrasound guided, so you don't injure the fetal part or the placenta. And you go right in to take the fluid out. This fluid has the shed fetal cells, which can be analyzed genetically. Again, with both chorionic villus sampling and amniocentesis, you can do rapid genetic tests like fluorescent in situ hybridization or FISH or PCR, and you can also culture the cells and do specific genetic tests. You can do gene deletion testing, everything I discussed on NIPT, but here it is more specific. On the amniotic fluid, you can also test certain chemicals like alpha fetoprotein is increased if there is a neural tube defect, which is a different category of problems, but your spinal cord is not closed fully or the brain top is not closed fully. So you have some suspicion on ultrasound about a neural tube defect. This fluid showing a high alpha fetoprotein will confirm that. In the quadruple test, the alpha fetoprotein is reduced in trisomies, but in neural tube defects, it increases. So the amniocentesis also, if it is done after 16 to 20 weeks, it's a fairly safe procedure, 0.2 to 0.5% loss. But there is a risk of losing the liquor. The liquor may leak, it collects back. And there is also a risk of preterm labor. So roughly 1% risk of preterm labor and pregnancy loss is there with amniocentesis. So we should be careful when we counsel the parents. If NIPT is able to be done, it's non-invasive, there is no risk of fetal loss. So do that first, and if it comes positive, then you can go for these invasive tests. There are other not so commonly done tests like percutaneous umbilical blood sampling, where actually you take the baby's blood sample with ultrasound guidance. That requires a much higher degree of fetal medicine development in the unit. Sometimes the fetal exchange transfusion, there may be jaundice, there may be IU infection. So you want to transfuse the baby or you want to do a procedure. Along with that, you can take the sample, but otherwise you wouldn't do the fetal umbilical blood sampling. Now we have in vitro fertilization. So in the early stage of IVF, you can actually take out one of the cells from the zygote, and then that can be tested as well. So this is pre-implantation diagnosis. So that's when you have a high family risk and before you implant, because IVF is expensive, it's also stressful and difficult. So before you implant, you want to make sure that you have 4 or 5 embryos. You want to pick the best one. You can do the pre-implantation diagnosis for this as well. So that's an option available. So these are the different diagnostic tests. And again, the NIPT can be considered a reasonably diagnostic screening test as a first line. If it's normal, you don't need a diagnostic test. If it's abnormal or it's not clear cut, then you go for the diagnostic test. In some cases of NIPT, you don't have adequate fetal material picked up in the mother's sample. In that case, you can simply repeat the sample as the pregnancy progresses. The NIPT can be done from anywhere from 9th week till end of pregnancy, and later in the pregnancy you have more fetal material, so you have the option to repeat the NIPT a little later in the pregnancy with a higher chance of the cell-free DNA from the baby being isolated. I hope this answers your question about diagnostic tests.
Yes, exactly. It's totally covered. So, Dr. Sridhar, what actions or next steps are possible for parents after receiving diagnostic results?
So we have the low-risk pregnancies, in which case you just reassure them and continue to monitor. All pregnancies have timing for different tests, so you continue to monitor the growth scan and so on. You don't need to do anything specific about this risk itself. Suppose there is a high risk coming out, then you discuss with the parents the options available. So I clearly said you consider NIPT, and then if NIPT is abnormal, you go for invasive testing. And if any of the soft markers are there, again, you link up with what we discussed already, that you have to weigh the risk, overall maternal age, the first trimester screening results, and either you can reassure directly or you request an NIPT, and then if it's normal, you reassure them. The soft marker itself needs further monitoring during the pregnancy, but most of the cases they don't need any intervention and they don't cause any problems to the baby later on as well. Once the result comes high risk and the confirmatory test, the diagnostic test is also abnormal, then we have the division of what to do with the pregnancy. Some parents may decide to terminate the pregnancy if the disease is high risk. I already discussed briefly about trisomy 21. Many parents may still choose to continue, but if it is trisomy 13, 18, a severe neural tube defect, or other conditions, they may decide to terminate. Again, your religious beliefs would come in play in this as well. So you have to counsel the family accordingly before you even offer the diagnostic test. What would they do? If they say they would terminate, then you can go for the diagnostic test. If they say they would not terminate in any case, you can as well just continue to assume the baby has or has not the condition and monitor the pregnancy. In some cases, it also alerts the team if something is picked up that needs intervention. You deliver the patient in a high-risk center referral unit so that you can be prepared. So this gives you the state of preparedness. And the parents are also emotionally prepared. They know that everything is not absolutely normal with the pregnancy. So it doesn't come as a shock to them when the baby is delivered. So this is how you approach an abnormal test.
Yes, that's right, Dr. Sridhar. So we will move to the counseling and support role of physician. So how can healthcare providers communicate the risks and benefits of antenatal screening to parents?
Most important thing here is increasing awareness, because most of the reason the miscommunication happens is because the pediatrician, mostly it's obstetrician who deals with it initially. Sometimes the parents come to the pediatrician for second opinion. So the obstetricians who are doing these fetal scans or requesting these fetal scans uh, do not have the full picture in mind. So this education that this session that we are recording should reach more people. So I request everyone to share this, and so that this information reaches, and there are many reliable sources to educate yourself from as well. So the fetal medicine centers usually are aware of this, but the fetal medicine center doesn't counsel the family because they act as a third party. They're doing the scan and giving the report to the obstetrician. It's the obstetrician who is looking after the mother who actually ends up counseling them. And if the obstetrician doesn't have enough knowledge, either they should ask the fetal medicine center or have a system in place where the fetal medicine center counsels at least the abnormal results. So many times it may just need clear counseling to the family that a soft marker is not anything dangerous. It just needs additional input and monitoring. And then we should be also careful to quickly emphasize to the family when the report is normal so that they don't carry the anxiety and the stress throughout the pregnancy, and it may spread to the wider family as well. So it's very important that this clear education system is in place, a clear network of communicating between professionals and clear communication with the family as a part of a multidisciplinary team. So if a parent has anxiety, they should be cleared immediately by experts. So the knowledge, spreading of knowledge, being clearly educated on the impact of these things and communicating with the family. In UK, for example, the midwives are all trained in this. They take the consent and they discuss, but in India or Egypt, I don't think that's happening. So that's an option that if the physicians themselves are busy, they have people who are educated and can counsel the family in the system. So there should not be a misconception that keeps aggravating the maternal stress in the pregnancy. And we should not do unnecessary tests which are invasive or even terminate a pregnancy, which is a very difficult thing for the family on the basis of some flimsy signs. So they should be very clear that what they are doing is appropriate. So this message should reach everyone. It's a very important message.
Yes, it's a great. So, Dr. Sridhar, by mentioning soft markers, can soft markers have any impact on the health of mother or fetus?
So usually there is no impact on the health of the mother apart from the anxiety generated. So when you're mentioning it and we talking of the brain, heart, gut, and everything, my parents start getting worried. They keep thinking about it, even if you reassure them. So there may be maternal anxiety. That's why the counseling has to be done appropriately. On the baby, there is usually, even if it's a choroid plexus cyst or a mild ventriculomegaly, it doesn't affect the brain function. If it is a echogenic gut, but the baby passes stool after birth and is normal, there is no need to worry about that. A mild pelviectasis on the kidney, again, if you monitor the scan and it is stable, it does need a postnatal follow-up scan, but it doesn't need any intervention if there is no hydronephrosis. If there is hydronephrosis, you would refer to a urology center. But apart from that, you don't need to be worried about any of these. The heart marker, if there is a fetal echo done, you don't need to consider doing a repeat echo after the baby is born, the echogenic intracardiac focus as well. Single umbilical artery, the baby's size may be slightly small, but if baby comes normal, you don't need to worry about it.
Great. So, Dr. Sridhar, about future directions, what new trends and innovations are emerging in antenatal screening for soft markers? And are there any maybe promising techniques related to earlier screening that may match with religious concepts, as you mentioned previously?
I mean, there are exciting developments because artificial intelligence is a code nowadays. I mean, keyword, buzzword. So artificial intelligence can be educated to pick up all these soft markers, look at all the risks, and the information that is need to be given to the family can be generated by AI, and the parents can read through it. Of course, the physician may need to check through it, but once it is done a few times, you know it's reliable. You can blindly give it to them because software is there. You have the input, and then the output is going to be similar. So in the beginning, you may need to put more stringent monitoring for what output comes from the AI, but that will remove most of the problems with time constraints. So the parents get the exact, and translation becomes very easy with the AI as well. So they could get it in the parent's own language, so it becomes easier as well. Again, you need to double check if the medical terms are translated properly and jargon free. So you may have generated reports. So we are talking of ChatGPT or some ChatGPT or similar software, which can be educated to do this kind of work. And also the risk profiling may be easier. So even if the doctor is not fully aware, by going through this AI based protocol, they will be clear. So this is the future direction. But the education part should be included in all pediatrician and obstetrician training in the medical school, and all doctors in general should have an idea, all midwives or nurses should have an idea of this. Anyone dealing with pregnant women should be clear about the impact of these so they can counsel appropriately in a timely fashion. So that's it about this aspect.
Yes, it was great, and hope for all mothers the healthy and safe pregnancy and deliver their babies with the health and well-being and well-being. So finally, I need to thank you so much, Dr. Sridhar, for your valuable insights and sharing it on MedSynapse platform. And I hope to meet you again in different episodes and invading a lot of critical topics related to neonates. Thank you so much.
Thank you.